Okay, good morning. We'll get started. Thank you guys for all joining in person, and welcome to all the attendees that are online. I'm Ashish Patel. I'm your physician-in-chief and the division chief of pediatric GI. It is my honor to introduce our speakers today. The thought behind this ground rounds, I'll really thank Dr. Schroeder for this, but as we've grown over the last 5 years, the pediatric GI division has gone from 15 docs to 25 docs. And so we've grown tremendously. And what that has led to is really the opportunity within a lot of our subspecialties to grow the faculty that are focused on these different subspecialties. And a huge part of that growth is mentorship by the senior faculty of the junior faculty. Now, Shauna is not going to like me calling her senior faculty. And they both went to University of Illinois for undergrad. I'm not sure at the same time, but it's they have both had an incredible journey. Dr. Schroeder, Shauna, completed her pediatric GI training at University of Colorado, where one of the sort of godfathers of EOE works and trained under. Dr. Sharlin is one of our pediatric success stories here. He attended Creighton here in Phoenix for undergrad. He did his residency here at Phoenix Children's. He then went to Cincinnati Children's for his pediatric GI fellowship. And then we were able to recruit him back here to grow the EOE, the Eosinophilic Esophagitis and Eosinophilic Gastrointestinal Disease program under Dr. Schroeder's leadership. So today we're going to have the opportunity to hear from both of them as they discuss the Eosinophilic Gastrointestinal program here at Phoenix Children's. So please help me welcome both of them. Thank you.
Good morning. Thank you very much, Ashish, for that introduction and for the opportunity to present today. When we were preparing for this grand rounds, Dr. Schroeder shared with me that she presented on EOE more than a decade ago. And it's really incredible that this field is still evolving and so much has changed in just the last 10 years. So we're excited to share today an update on eosinophilic esophagitis. So my name is Colby Sharlin. This presentation was supported by a grant from our National Pediatric GI Society. We also have clinical trial site involvement here for a few biologic medications, as well as vonoprazan. Otherwise, I personally do not have any other financial disclosures.
I'm old, so I have a few financial disclosures, but a speaker and consultant, but none of the things that I will speak on today will impact our presentation. And then we are a big clinical trial site, and we'll go through all the clinical trials that we've been involved with and the future ones that we plan to enroll our patients in as well. We have a long list of learning objectives, so we'll try to get through these expediently, but we're going to define EOE and diagnostic criterion and then go through the natural history of the disease. There's a huge disease burden associated with EOE, and we'll go through the different aspects of that. Clinical signs and symptoms, specifically in pediatric patients. We'll discuss the traditional diagnostics and findings that we see when we do endoscopies. Our current treatment methods, we'll explore future treatment methods as well as the clinical trials. And then we'll discuss novel advances in assessing disease severity without having to do endoscopy. And then sort of my passion, and hopefully now I'm getting Dr. Sharlin on board, his passion is innovative surveillance tools for monitoring our patients with EOE, and then recognizing the importance of a multidisciplinary and collaborative effort for managing our patients with EOE. So without further ado.
Let's talk about what is EOE, or eosinophilic esophagitis. This is an esophageal disorder characterized both by chronic inflammation and then clinical signs and symptoms of disease. And this is primarily esophageal dysfunction. And shortly we'll talk about what does that look like for a patient or a family, or if you're a physician meeting this child, what does that look like when you're interviewing them? The biopsies that we obtain during endoscopy really meet a diagnostic threshold. What we're looking for is the allergic cells or eosinophils present under the microscope to meet the threshold for a diagnosis of EOE, we do need to have at least 15 eosinophils per high-powered field. And it's important to note that this is a patchy disease, and so we have to look at a number of different levels in the esophagus. The other important aspect is that EOE is not the only thing that can cause the presence of eosinophils in the GI tract. So it's important to exclude other causes, though they may be less common or more rare. It's important to consider them in each individual case. As I mentioned, EOE is a progressive disease, and here you can see in this cartoon depiction a normal esophagus on the left visually or endoscopically, and then the histology below shows that there's a healthy non-pink esophagus. And as we can see in the next sort of chapter, we can see an inflammatory state characterized by the pink eosinophils. Visually in the endoscopy, we can start to see changes in the mucosa or the surface of the esophageal lining. We can see swelling, narrowing. And as that progresses, that narrowing too can progress and cause more and more dysfunction clinically, and visual evidence of narrowing, even strictures in some cases. And microscopically, we see similar changes, fibrosis or scarring, especially in the lamina propria, and other changes that can contribute to this dysfunction. This is the most common cause of food impactions and dysphagia in children. And the other important thing to note is that when we're seeing a patient who has this diagnosis, it's not always the case that their symptoms may align with how things look on the inside or under the microscope. And so it's really important that we have a good surveillance of this disease and stay kind of connected with these patients to prevent progressive changes such as fibrosis that may occur with time. And this is particularly important because a delay in diagnosis or a prolonged period of untreated or unmanaged disease can cause progression. And so studies have found that every 10 years of untreated or active inflammation doubles the risk for stricture formation. Also, this disease is relatively new, and awareness is something that we're continuing to work on, but there is a big delay in diagnosis from initial presentation with symptoms both for children and adults. And so children, the delay in diagnosis has been found to be about 4 years, and for adults, it's even longer, up to 11 years. It's very common actually to be seeing a child in our clinic and then find out, for example, that dad has been choking for years or went to the ER and had a dilation but never received a diagnosis. And that's a common story that we all have experienced in our care of the children with EOE. The burden of EOE is one of the things that I think has changed the most probably since Dr. Schroeder talked about this first year. So we have, of course, some limited studies available across the world, but here you can see in the United States, prevalence is a bit higher than other places. The global incidence is estimated to be about 5.31 per 100,000 inhabitant years, and the prevalence is about 40 cases per 100,000 inhabitant years. Those numbers are hard to interpret as a trainee, as a physician, as a nurse. And so I think what's more meaningful is that about 1 in 700 people have EOE in the United States. And this was from a study that was just published this year. So certainly a more and more common disease that we're dealing with. And the incidence and prevalence have increased in time over the last 20 years. When we have a sort of storyline like this, it does suggest that there's other factors at play other than just increased detection of the disease or increased awareness. And so there's been some epidemiologic studies and some bench research that have looked into some of these early life environmental exposures. I'd like to highlight a few of these that may be modifiable risk factors for disease. And so they can be some things that occur in utero, in infancy, or in the NICU, and even as children and even adults. Some of these things can contribute to an increased likelihood of developing EOE. And so some of them would be the mode of delivery. C-section has been associated with an increased likelihood of later developing EOE. The mode of feeding, certain maternal actually exposures to PPIs, which we'll talk about shortly here as a treatment for EOE, but also as a risk factor that's been identified as a potential risk factor. One of our colleagues here at Phoenix Children's, Dr. Ben Wright, is an allergist, and he focuses on looking at environmental exposures that break down the protective barrier in the esophagus. It's been found that detergent from household cleaners and products and toothpaste may be responsible for breaking down the barrier and then potentially responsible for the increased incidence of EOE in children and adults. How about outside of the GI and allergy clinics? This is certainly something that all of us are dealing with. So in the emergency department, studies have looked at how common it is to see children with EOE or complications from EOE. So from 2009 to 2019, there was a triple in the number of encounters for EOE related issues, and it's projected to double again by 2030. Sort of as I alluded to before, it is very common for the adult world to see cases where people present without any other care until they have a food impaction. So it was estimated that there were over 700,000 ED visits for food impaction, strictures, or dysphagia in men less than 40 without a formal diagnosis. And the cost for EDs in our healthcare system is profound as well. So a study in 2024 using available data found that the estimated costs from EOE related care was $1.3 billion in that year alone. The burden is not just on us, of course, so this is more a burden on individuals, patients, families, schools, and caregivers. And that's really important for monitoring this disease, making treatment options, thinking about surveillance and care as a whole. And so certainly a child at school in the cafeteria may have a limited ability to participate in eating, or may have to make accommodations that we'll talk about here shortly, that can be embarrassing or hard to accommodate. In a school setting or out to lunch or dinner with their friends, it can impact the ability to participate in play dates or birthday parties where they have foods that are triggers that have been identified for them. All of this can lead to emotional burden for individuals and families. Depression and anxiety are common in children with EOE. And then, of course, there's a huge burden on the family financially and time-wise as diagnosis is reached, and then treatment is pursued, and surveillance and recognition of what it's not often just one stop shop, get a treatment, and you're good to go. So this is a chronic disease, and so involvement for the families is often pretty chronic as well. So I'd like to take a step back and think about EOE as a whole. How does this work now that we've recognized it's becoming more and more common? Like many conditions, there's not necessarily one single cause of EOE. So when we think about this, we are looking at both a genetic predisposition, a little bit about some early life exposures or risk factors that may contribute and interact with the gene environment as well. But when a child has this exposure to the environment and a genetic predisposition, they certainly can see then changes in this esophageal barrier that's protective. When that happens, the esophagus may be exposed to certain allergens. The vast majority of the time, it is food antigens that triggers this inflammatory cascade. And so this little graphic shows the least common on the left and the most common food triggers, which we'll discuss a little bit more here down the line. But the inflammatory cascade starts with increased TSLP and IL-33 alarmins, and those recruit Th2 cells to the esophageal epithelium and it starts an inflammatory cascade. So IL-4 and IL-13 are important factors for some of our biologic treatments, but this recruits eotaxin, eosinophils, and other inflammatory cells to the esophagus where inflammation takes place and progresses if left untreated. Interestingly, there's a male predominance of this disease. So up to 60 to 70% of cases that have been identified in epidemiologic studies show that this is a male predominant disease. There's also some specific conditions that have gene-related changes, such as Loeys-Dietz or Ehlers-Danlos, that have specifically implicated genes that may put a child or an adult at increased risk for the development of EOE. Talk a little bit about some of the common comorbidities. And I think this is really important because we're not always seeing these patients that have these common comorbidities in the GI clinic. So you may be seeing them in your allergy clinic or ENT or your general pediatric clinic. Of course, eosinophilic esophagitis is an atopic condition. 2/3 of EOE patients have other allergic conditions such as asthma, eczema, allergic rhinitis, or IgE-mediated food allergies or true food allergies. In fact, actually, one of the treatments that's used, oral immunotherapy for food allergies, has the potential to induce EOE. So you may often hear about the atopic march, and EOE is certainly a part of that. But it's not just allergic conditions. And so autoimmune conditions have been found to have an increased association with EOE, as depicted here, both autoimmune GI conditions and others as well. So IgA deficiency, celiac disease, ulcerative colitis, and IBD. So it is quite common for us in the GI clinic to see kids that have IBD are being treated for that, and on evaluation are also found to have comorbid EOE. And so treatment regimens can get tricky for some of these autoimmune conditions where we're using biologics or immunomodulating medications as well. And then more broadly, EOE can be associated with autism and autism spectrum disorder. So a study of EOE patients found that up to 22% of them also had a diagnosis of autism. And then, of course, patients who've had prior surgery or repair of their esophagus from TF or esophageal atresia or increased risk of the development of EOE. Studies have shown between about 10 to 20% risk of development of EOE. It's possible that the motility that's changed from these surgeries causes more stasis in the esophagus, more exposure, prolonged exposure to acid or other things that may disrupt the barrier and expose these food antigens over a longer period of time in the actual modified esophagus or esophagus that has modified motility. So what are the signs and symptoms that children with EOE may present with? I'd actually like to start with the adults and adolescents because I think they have the more classic or stereotypical symptoms of EOE when they may present. So certainly, like we talked about, a food impaction in the emergency department for adults may be their first and only kind of sign that they experience. But more commonly, we also see true dysphagia, trouble swallowing, the sensation that food is getting stuck on the way down. And this may be with solid foods or harder foods. Adults can also have persistent heartburn over the course of many years. And we know that acid exposure itself may be one of the things that disrupts the lining or the barrier in the esophagus. When we look sort of down the line at our patient populations, symptoms do vary quite a bit by the age of the child at the time of presentation. So school-age children may present with heartburn, belly pain, vomiting, kind of difficulty with some of those harder foods or meats as they're trying to swallow. But infants and younger children have even more sort of broad or vague symptoms. So vomiting, poor growth, malnutrition is common in EOE patients when they're presenting at a young age. Certain food preferences, regurgitation. One of the things that's a little bit hard to elicit from a patient would be some of these compensatory eating behaviors. So we often will have a patient that is seeing a feeding therapist and we have this information more readily available. But other times it's a lot harder to identify. And so we try to ask really particular questions. But some of these accommodations or compensatory mechanisms would be using fluid or condiments to help lubricate food in the esophagus. So a child that likes chicken nuggets, that they are drenching it in barbecue sauce. It's a very common sort of presentation we see because chicken nuggets, of course, are very popular. But also modifying these foods, cutting them up into really small pieces or bites, eating really slowly, especially with their age-matched peers, relative to their age-matched peers. Avoiding these foods altogether, whether that's picky eating, feeding refusals, or just more self-selected against some of these harder foods. Chewing excessively, and turning away tablets and pills. Some of the questions that we would ask, or that if they come up in your clinics that may help elicit some of these is, would you feel the sensation that food is getting stuck on the way down? Do you eat steak? When you eat steak, do you have to modify that with smaller bites? Do you need drinks with your beverage or with your meals or beverages with your meals to help? And I also like to ask the families, what does it look like when your child's eating? From mom's perspective or dad's perspective, watching that child, what does it look like? How long does it take? To really get a really thorough history on the feeding process for the child and some of these more subtle adaptations that for them may be normal at this point, but are more habitual and have changed for a particular reason the family has yet to identify.
So these are just a few cases of patients that presented in probably like the last 6 months in clinic. So these are just examples of patients that may show up in your subspecialty clinics or in your primary care clinics that you should sort of start thinking about, okay, oh, there are some of these clinical symptoms or risk factors that I should probably get them over to a GI for a diagnosis. So the first case, we have a 12-year-old male with a history of autism feeding issues. Pretty common. They describe the parents' avoidance of meats and hard texture foods his entire life. He has a very restricted diet, only eating carbs and dairy-based foods, and he's dependent on supplemental liquid nutrition for adequate growth. He also has seasonal allergies and chronic congestion and is following up with the primary care to assess his allergies and get a refill for his, supplemental nutrition. So in this case, we have this special patient population, our autistic patient, and then the chronic feeding issues. Sometimes these patients just get labeled as behavioral feeding dysfunction, or extreme picky eaters, or even the diagnosis of pediatric feeding disorder, but they never get a medical evaluation. Sometimes parents will complain of behavioral changes and then they magically put them on a gluten-free and dairy-free diet and all their symptoms go away. So was there an underlying medical condition that they were treating all along? A 6-year-old with allergic rhinitis was prescribed sublingual immunotherapy by an allergist and was seen in the clinic for new throat clearing symptoms and this fullness sensation in throat. Parents report whenever the patient is eating that they're clearing their throat. And this is what Dr. Schroeder is describing is like, what do the parents observe when they're eating? The patient may not even notice that they're throat clearing, but this would be something triggered that the parents notice. He also has intermittent complaints of generalized abdominal pain. And then obviously was prescribed SLIT because he has seasonal allergies with nasal congestion. So again, this patient is actually being prescribed environmental allergens swallowed, and then now on this esophagus that doesn't have a healthy barrier is driving this inflammation. Not only can this happen with SLIT therapy, we now are seeing this at increased incidence with oral immunotherapy for patients who have true food allergy that are being given either small amounts of peanut or milk protein. And then the last case is a 2-year-old female with tracheoesophageal fistula. She had been feeding really well until starting solid foods, and she's now starting to pocket or chipmunk foods in her mouth. Again, something that would be noticed by the parents. Meal times have now increased and preferring liquids and purees over solid foods. There's also chronic vomiting and regurgitation despite PPI treatment, and had a recent hospitalization for pneumonia. So again, this is a very special patient population that we should be thinking about EOE, potentially anastomotic stricture, and you would get an upper GI and imaging, but again, has not had any of those complications post-operatively, and this was sort of starting when we started solid foods. So that should also be a key that like symptoms start with the introduction of food proteins in their diet.
So of course, how we diagnose EOE is important and hopefully evolving in the next decade of care, but currently the only sort of way we can diagnose EOE is with an endoscopy and biopsies. So when we do an endoscopy or an EGD for a patient, we like to get a lot of samples. So at least 6 samples from different locations throughout the esophagus is an important thing because EOE can be a patchy disease, and certain conditions may, for example, reflux, have more eosinophilia in the distal esophagus, but absence in the proximal esophagus. So it's important to understand the extent and the locale of disease. We do typically get biopsies from the stomach and small intestine during an EGD, particularly if there's symptoms or visual abnormalities on the endoscopy. Unfortunately, we don't have a non-invasive diagnostic tool for EOE currently, so it cannot be identified with skin prick testing, blood testing, or imaging studies. Imaging can be helpful in managing some of the disease, but it's not a diagnostic tool. This is what got me excited about pediatric GI was endoscopy. And so seeing some of these visual abnormalities is really important. There's a validated scoring system called EREPS that we use to characterize the extent of disease for EOE. And it's an acronym that stands for edema, rings, exudate, furrows, and stricture. I'm gonna go to the next slide, bigger pictures. In the middle, you can see the healthy esophagus with the normal vascular pattern. And each of these findings depicted here. So in the top left, you can see edema or swelling of the esophagus that obscures the normal vascular pattern. In the bottom left, you can see here some exudate or white plaques or papules along the esophagus, which is an inflammatory change as well. the top right, we see a fibrostenotic change, especially with more advanced disease, so rings that could cause progress further to stricture. And in the bottom right, we can see furrowing, which is our vertical lines down the esophagus. It may be that the swelling is so severe in between those areas, we can see these furrows, but it's also believed to be an inflammatory change. This is a validated scoring tool that's used both in the diagnosis and in the monitoring of response to therapy in patients with EOE. Under the microscope, what do we see? Well, we have, of course, the eosinophils that we discussed. Interestingly, there's been some drug studies that have eliminated eosinophils entirely from the esophagus, but this disease persists. And so there's been an increased sort of look into some of these other histologic features that define EOE. They're not necessarily part of a diagnostic criteria currently, but some of the things we're looking out for are basal zone hyperplasia, or expansion of the layers that regenerate cells, lamina-appropriate fibrosis, or scarring of the esophagus, if we are able to get enough of the biopsies to show the lamina propria, which is deeper to the epithelium. And then some more subtle things, abscesses, surface layering, dilated intercellular spaces. All of these things are not present in a healthy esophagus under the microscope. So once we have a diagnosis of EOE, how do we treat it? Well, first, what are the treatment goals? We want to get, for the patient, their symptoms under control. And then we want to get the inflammation under control so it does not progress and cause complications. How do we do that? Well, we monitor patients' symptom scores, we monitor patients endoscopically, then histologic remission is also vastly important. And so in clinical use, our goal is to get less than 15 eosinophils after treatment. Clinical trials aim for a more stringent 6 eosinophils per high power field. There's a lot of considerations through treatment, and we're going to talk about those with each of these options here. So dietary elimination was one of the first things that was used to treat EOE. There's also medications that we'll go through in more detail, PPIs, swallowed topical steroids, and new biologics. For diet, as I mentioned, if you look at the little graphics there, the least common triggers, the most common, dairy being our #1 food trigger for EOE. Historically, it was highly successful at achieving remission if we removed all these food triggers at once, then tried to add them back and identify the particular trigger for an individual patient. Of course, that is a huge change to the child's diet, a growing child that may already have nutritional concerns. Though it's a highly effective treatment, it's very hard to implement and requires a lot of time, effort, and endoscopies to identify those triggers. So more recently, there's been a shift to doing step-down therapy that's been supported by trials as well. And so if we remove the most common trigger, not based on skin prick testing or blood testing, but based on our clinical research and experience and studies, then we can try to remove the most common 1 or 2 foods, see if that is effective at treating, especially, as I said, in a growing child, where we may not want to limit food availability or options for them. So dairy and animal milk products, cheese, are the #1 trigger for EOE. Approximately 60% of patients have dairy as one of their triggers. And there's been some recent studies that found if you eliminate dairy alone, that can be effective for achieving histologic remission in patients up to 50% of the time. So that's a very common treatment approach that we'll use if a family wants to pursue diet therapy. If we're removing other foods, we may work our way down the list, and maybe other considerations about the child's home or school environment or other allergic or atopic conditions that may be implicated in food allergies, for example. If a patient is not successful with diet therapy, or it's just not the right treatment option, we'll then turn to medication options, which can be first-line treatments. So PPIs have a long history of being involved with EOE. You guys, of course, know them as antacids, but there are anti-inflammatory properties that have been identified on the esophageal epithelium in bench research. And you can see in the picture, there's a number of different mechanisms that this may be occurring by. The antacid properties may help restore some of that disrupted barrier, but then there's direct effects on pathways implicated in EOE, SAT6 and eotaxin-3, and eosinophil recruitment to that epithelium that can be prevented by the use of PPIs. Some studies show that the treatment success with PPIs when used at these higher doses is between about 40 to 50%. One thing that's super nice about PPIs is they're readily available. They're well kind of described and used throughout the history of medicine. And it's largely a safe medication. Some of the side effects that are becoming maybe a little bit more widely publicized would be increased risk of fractures with long-term PPI use, increased risks of infections such as C. diff or pneumonia. So families are certainly paying more attention to that when thinking about PPIs as a long-term treatment option. And that's the other thing I maybe didn't mention about treatments is that this is a chronic disease. And so the treatments are intended to be lifelong to keep this inflammation in check. Studies have shown that when we remove these treatments after we've been in remission, that disease returns. Just because a family chose one treatment option, however, does not mean they have to stick with that if the child is now going off to college and can't remember their medicines, or has a change in their ability to cooperate or adhere to a therapy. The other first-line treatment we often use is swallowed topical steroids. The way that we like to kind of explain this to our patients and families is that it's like if you have eczema and you rub a steroid cream on your skin. Same concept, except we can't rub steroids directly onto the esophagus. So instead, we swallow them. This comes in two forms, respules that are mixed with honey, agave syrup, or other liquids that increase their dwelling time on the esophagus. These are typically used twice a day. And then there's recently an FDA approval for a pre-mixed Eosinophilic packet that has the same sort of mechanism of dwelling on the esophagus. The other way that steroids can be administered in this fashion would be with an inhaler. We use that without a spacer so that it goes into a swallowed fashion into the esophagus. So this can be done with Flovent or cyclosinide to achieve a similar effect. Studies are pretty good for efficacy for swallowed topical steroids, about 60 to 70% in observational studies. There are some side effects with steroids that we monitor for, main one being thrush in the mouth. So we ask our patients to rinse sometimes afterwards or in the esophagus. And then less common side effects would be adrenal insufficiency, growth suppression, or effects on the bone mineral density and growth. And the new kid on the block would be dupilumab, which was approved a couple summers ago, 2-3 summers ago, which is a biologic medication that's used to treat EOE. This targets the inflammatory cascade directly, IL-4 and 13. And it's also used to treat other atopic conditions, asthma and eczema, all at different dosing regimens. This can be really helpful in a patient who has refractory disease or has multiple atopic conditions that may benefit from its use. There's also a subset of patients, sort of like we discussed, that may not be able to adhere to twice daily treatments, especially as they're going off to school or having increased autonomy or independence. So this is a highly effective medicine. It's not something that needs to be done daily. Depending on the child's age and weight, this is every 1 to 2 week medication that is done through subcutaneous injections. It actually was the first FDA approved medicine for EOE. With all these options, how do we, make this decision on which treatment to start with, and how do we make sure it's still effective? First, use shared decision-making in our clinics with our patients and families. What is practical for the child? What nutritional considerations are there? Is this child a good candidate for diet therapy, or is that something that's going to be too restrictive for them in their growth? Once we've made a decision, it's important to assess the effectiveness for those treatments. So for the most part, everything takes about 2 to 3 months to see an effect. We'll repeat some sort of endoscopic assessment, which we'll talk about some of the options here at Phoenix Children's shortly, to make sure that this therapy is effective. We went through the efficacy rates, and not every treatment, even if you're adhering to it, is going to be effective for that particular patient. And so it's important to assess response. And like we discussed, not everything matches up from the outside looking in and when we're actually looking at the insides. We don't want this disease to progress and cause complications or worse quality of life. And so we want to make sure that remission is able to be achieved and then sustained. Dupilumab takes a little bit longer to see a response. And so endoscopies may be repeated on a little bit more of a delayed time frame. Once we've achieved remission, we want to make sure that the child, especially if they're growing, is maintained in remission. So we may use assessments on a longer period of time, every 1 to 2 years, to make sure that remission is sustained and that active inflammation is not present at risk for progression.
So future treatments and clinical trials, we've been really fortunate here at Phoenix Children's. We really have about 800 patients with EOE in the state of Arizona. And obviously being one of the largest children's hospitals, we have a huge catchment area. And so we've been able to really participate in a lot of these studies. So when I first got here 12 years ago, they were just finishing up and wrapping up the phase 2 Eohilia, or the budesonide, viscous budesonide study. And then when I came on board, the first sort of big industry study I got involved with was the phase 3 trial for budesonide. And we had at least 8 patients, I think, enrolled in that study. Then we sort of moved on to a new biologic that was on the block, which was lintrilimab, which was actually an anti-cyclic 8 antibody that would actually completely deplete eosinophils, as well as having a mast cell effect. And we had about 10 patients in that study as well. It was an infusion medication. And the one thing we really learned that Dr. Sharlin mentioned is that although we completely wiped out eosinophils, we did not stop disease. Patients did not meet primary endpoints for improvement in their clinical symptoms, nor did they have improvement endoscopically with edema in their esophagus. The next biologics we did a study on was the dupilumab studies. We enrolled patients in the TREAT study, which was 12 and up. We had about 10 patients in that study. And then we did the Liberty study for pediatrics for dupilumab and had probably another 8 or 9 patients in that study, and feel that we had a significant contribution for this medication to have finally an FDA-approved drug for EOE. Cendikimab is another IL-13 inhibitor. It blocks the IL-13 receptor. And that medication was also an injection medication. We completed that study. Well, it just stopped. But there was good positive results. But unfortunately, I don't think that drug will actually come to FDA market as of right now because of sort of market share and financial things, but we were able to participate in that study. A new kid on the block is the tezepelumab. It's an anti-TSLP antibody. So what Dr. Sharlin sort of showed in the pathophysiology is actually upstream from blocking those cytokines IL-4 and IL-13, but it's an anti-TSLP antibody that will sort of block both the Th2 recruitment as well. It's already approved in asthma for 12 and up, and this is also an injection medication. It's currently a phase 3 double-blind placebo study, and we'll be wrapping up recruitment probably in the next 2 months. Likely, we'll also end up doing the 1 to 12-year-old study for those patients. The other phase 2 and phase 1 studies are in adults, so not available to us in pediatrics. And then vonoprazan was actually, it's a PCAB, which is another anti-reflux medication. It's approved in adults for erosive esophagitis, GERD, and H. pylori, and it's an oral medication, which would be really nice. That currently, unfortunately, is on hold. I got an email this week, but we'll see. Hopefully they'll come back around and want to pursue studying that. So we know that assessing disease severity is really important, having repeat scope, as well as taking biopsies. So those 2 components. But are there ways that we can assess the severity of our patients' EOE without having to do that? So I think a non-invasive, less expensive way, something that's probably underutilized in pediatrics compared to the adult world, is imaging studies with esophograms. So this is a picture on that first panel here of a barium tablet that would dissolve, but it's stuck in the, there we go. And maybe not. Yeah, there you go. Oh, there we go. Stuck in the proximal part of the esophagus here. In this panel, we actually can see the tablet is dissolving and you have like a feathering look of the esophagus. This represents trachealization or some of that fibrosis. And then the last panel, we actually can see a long segmented narrowing. So this is a patient who has a stricture. So esophograms may be really helpful if we have persistent dysphagia. We're concerned about a stricture and we can identify, do we have a short segment, long segment stricture? Where is the stricture? So it can help in preparation for endoscopy and dilation. So the other aspect is they're a clinical assessment tool. So a bunch of eosinophil files, as well as pathologists and allergists, got together to look at, can we take components of our treatment goals, our clinical symptoms, what we're seeing grossly on endoscopy, what we're seeing microscopically under the microscope, and give a score to give it disease severity. We already have this in other inflammatory bowel diseases. So you may be familiar with calculating PUCIs or PCDIs for your ulcerative colitis and Crohn's patients. So having our electronic health record here, we were able to actually build in, and we're one of the first places to actually do this, build in the IC index into our QUIP notes. And so any patient that's coming to the hospital for a visit in the outpatient setting, we can actually click on the box, and then it uploads the disease severity index. And we started this as a QI project within the division. And we're actually then able to score patients. So what we want is to be able to see our patients back in a more timely manner, avoiding complications. So Dr. Greenhall started this as a resident and has now continued this as a QI project as a fellow. And he was able to present this at our NASPGHAN National Conference this past year. But this was retrospectively looking back at our patients and then giving them an IC score and seeing how many patients were actually having inactive, mild, moderate, or severe disease based on the IC score. We want to see our patients in a timely manner to avoid the complications. And he was able to actually describe what complications we were seeing. So most commonly was malnutrition, decreased growth trajectory, food impactions, hospitalizations, and persistent inflammation despite immunotherapy. And you can see that in moderate disease patients, there were 82 of them, 35.4 were compliant with recommended follow-up for that time period, which would have been within 3 months. And so our next future step goals will be to actually looking through prospectively with now using the IC, can we follow these patients in a timely manner and then decrease our complication rates. One of the other things that Dr. Sharlin's doing is a FIFA clinic. So it's a food impaction follow-up. So if anybody is, whether it's ENT or surgery or us, GI is removing a foreign body. We did a tablet, not necessarily just food, but food from the esophagus and taking biopsies. He's seeing these patients within 2 weeks to actually go over biopsy results, consult with the family and patient, and do education on the likelihood of them having EOE and getting them on a treatment. We also have functional assessments that we're starting to use more frequently, and this is called EndoFlip. It stands for Functional Luminal Imaging Probe. And we know that patients with EOE have reduced distensibility of their esophagus because they're stiff, and this can increase our risk for food impaction or requiring dilation. And there's a significant correlation between the esophageal diameter along with what we're measuring on our diameter with our EndoFlip catheter. It's not currently being used on routine care basis everywhere, but we're starting to use it a lot. Of larger centers are using it, and it may actually be more sensitive for picking up subtle strictures. If you think about your esophagus, our scope is about 10 millimeters, and if we can drive our scope through, we may not actually appreciate that our patient has a subtle stricture. Having a diameter of 11 to 14, 15 is not normal, and those patients likely will have dysphagia and need some sort of dilation. So this is like a picture, it's almost like a heat map you can appreciate here. This, again, I'm not going to be able to do this with the, here we go. There we go. So this is a nice distended esophagus. It has a normal diameter. Here, this is our lower esophageal sphincter. This here is a distal stricture. The diameter is much smaller than we would appreciate as we fill up this catheter with water. And then here we have a proximal stricture that's noted. So next, I really want to get into innovations in care and our sedation-free surveillance, which is something I'm really proud of. We're one of the few centers in the country that actually provides 2 sedation-free options for our patients with EOE. Currently on the landscape, there are 3 options. We have our transnasal endoscopy. I'm putting an arrow on here, but not on there. Oh, there we go. So here we have a patient that's actually getting scoped while they're awake. And then this is the esophageal string test. This is called the cytosponge. Currently the cytosponge, again, would be swallowed and then it deploys within the esophagus and you would pull up the sponge and you actually would get some epithelial cells. Then you're able to place that on a slide and look to see if there's edema or basal zone hyperplasia, or if there's eosinophils there, but it's only approved for 18 and up. So currently we have the ability to do both esophageal string tests, which I'll show you a video of, as well as the transnasal endoscopy procedure. So how did we bring these new technologies to Phoenix Children's? And I think this is like a lesson for any clinic. If you have a new innovation or technology that you're thinking about, how to approach it and bring it here. There is both from a research standpoint and from a clinical standpoint, everyone has been super supportive here. So I had a patient in 2019 that came to me and was like, I'm really tired of going to Denver for my transnasal endoscopies. Is there a way that you could do it here? And thinking about it, I'm like, yeah, I could do it here. I can learn how to do it. I just got to figure out how I can get the equipment, get the space, get the people. And so they had a leadership circle grant at that time. And I sort of put a Shark Tank presentation together pretty much and got funding. And so we were able to purchase a tower and a bronchoscope, as well as a little funding to go get trained in Denver. So we went 2019 to go see how they set up their clinic, came back in basically January, we did our first clinic, and then COVID happened. So sort of put a pause on that. And then we restarted about 6 months later. But we were able to identify a space up in the clinic setting. So we didn't have to use OR time. We did obviously need anesthesia because this was sedation free. And then we were able to secure amazing support staff. This was Terry, my endoscopy tech, that helped me at first. And now I have an amazing medical assistant. Cynthia is the jack of all trades and does everything EOE, who we couldn't do this without, as well as Ellen, one of our nurses, who is so comforting for our families and patients. In 2021, a company developed a disposable scope. It was FDA approved, but had never been used in humans. And so they picked 3 big centers to use the scopes. And so we brought the scopes here and we started using the disposable scopes. So the main issue with the bronchoscope is that it needed to be cleaned. The turnaround time was about a half hour. And so I really could only schedule 1 to 3 patients, maybe in a clinic block, which is not very efficient if you think about it. So with the disposable scopes, we've now been able to add 5 to 6 patients in a clinic block to actually do their procedures. And we've gotten so busy. We've now trained 2 physicians, both Dr. Sharlin and Dr. Tran. And Dr. Tran has now taken this concept of transnasal endoscopy, which we're using for esophageal monitoring, potentially looking at H. pylori in the stomach. We're able to take biopsies, looking at for erosive esophagitis in our patients that have severe GERD. He's now taking this in the inpatient ward to the ER. He's doing full EGDs. He's doing GJ tube conversions. He's using it for screening for our varicose patients. So there's like a whole new world of transnasal endoscopy that we're able to explore now. So that's our story there. Going back to sort of like the EOE part of things, who is a candidate for our less invasive testing? So I think there's 2 big considerations. For the string test, our patients definitely have to be able to swallow pills. So it's about the size of a Mike and Ike or jelly bean. If they're unable, probably not going to be able to get that pill down. The other is, this is a screening tool. This is not a diagnostic test. So I still think the main thing is like, have you already had an endoscopy and a diagnosis of either, of EOE, and that you're coming in for monitoring of disease activity. And then how are your symptoms? So if asymptomatic, they've been stable on their treatment, this is a really good tool to use. If they're having dysphagia symptoms or they're having heartburn symptoms, it's really hard to tease out on the results if there's eosinophils, if this is from reflux disease or if this is from EOE. And so in those patients that have symptoms or that we're making sure that their disease is actually being treated on their current treatment, we'd recommend tissue. And so our transnasal scopes, we've been pretty much doing an offering to like a really cooperative 8-year-old on up. And the main question I usually will ask is if they're okay with nasal sprays. So if they're okay getting their nasal sprays for their allergies, a lot of these kids are allergic, they'll probably be fine with the transnasal scope. And then again, do they have overlapping disease that we need to worry about? Like, are we worried that they have a yeast infection? We could definitely do everything that we're doing with a traditional sedated scope with the transnasal, with the exception of doing endoflip. And that if we have, and we're concerned about motility issues or a stricture, would want to definitely bring them back to the OR. So this is a video. So this is really how we sort of go about our transnasals. Oh, is it volume on here? I don't know. No, it's, sorry. There's good, we're good. So administration of nasal lidocaine and Afrin we'll put in their nose and in the back of their throat. I have a candy spray to help mask the bitter taste. And then oftentimes my patients will want to use VR goggles for distraction. And again, this is done all outpatient. And then we're able to intubate the nasal passages. I've become very good at looking at swollen nasal turbinates and adenoids as a GI doctor. But here you can see passing through the nose. There's the adenoid tissue there. And then there you are in the oropharynx, that's the UES right there. I'll ask the patient to swallow and then I'll advance the scope. And there's air and water, so I'm able to actually insufflate the esophagus, be able to get good view of what things look like, and then take biopsies while I'm there. There, you can see at the lower end, that was the lower esophageal sphincter. Now I'm in the stomach. This is not me, actually. This is pretending it's me. I don't have a beard. So again, then we're into the small bowel. Here you can appreciate the villi. You know, taking that nice picture of the small intestine there. And then as soon as you take your samples on the way out, here you go. You can see the forceps. The pieces of tissue are just as, they're a little bit smaller, but I get as much information as I would with a traditional endoscope. And then you just pull it out. They get a big popsicle and they get to go home. This is the string. So this was produced by the company, but again, you can see the size of it's about the size of a jelly bean or a Mike and Ike. This is obviously an adult who's able to take a pill themselves. What I typically do will unravel the string. I will hold on to the end of the string and I will have the kid hold on to their bottle of water and I will place the capsule in their mouth and then they will just worry about getting the string down. Or the capsule device down. I will tape the string to their cheek. It's there for an hour. The capsule device itself is a vegetable-based capsule that has a little metal ball in it to help weight down and allow that capsule device to travel quickly. We know the height of our patients represents the length of their esophagus, so we can calculate that. So we cut it based on the length of their esophagus and send it to a lab. And then we get a lab score or cutoff value for whether or not they have more than or less than 15 eosinophils, which is our clinical cutoff for EOE. So that's the string. Really quickly, I think this is really key as a multidisciplinary approach. I know I only have a few more minutes, but it takes a village to really manage these patients. So we do have a clinic. We have 5 half-day clinics a month where GI, allergy, and our amazing dietitians are together. I will shout out our fantastic pathologists. Not only do they give us EOE numbers, they also give us an EOE microscopic assessment score. That is not common in every institution. So we really appreciate our pathologists. Our other specialists that may recognize our patients to get them here for referral. And then our psychologists and feeding therapists who work so hard sort of unraveling these pediatric feeding disorders that our patients have on top of their active EOE. And then our ER docs who are obviously seeing our food impacted patients. So with the PCPs online, to feel comfortable renewing their medications, at least their PPIs and swallowed steroids, if they've been lost to follow-up, or if you were like, when was the last time you had a scope, and it's been 4 or 5 years, making sure they get re-referred back to us so we could do some sort of monitoring of their disease activity. And then this is our EGID clinic. Again, we are the GI team. Our allergy team is Dr. Bauer, Dr. Wright, Dr. Crossay, and we have a new nurse practitioner who can see our patients and follow up, Diana. We have amazing registered dietitians. And then it really open to not only just EOE, but also non-EOE EGIDs. If there's patients in the community that are starting OIT and they're starting to have EOE symptoms, any patient with EOE and other allergic conditions, it's a great clinic to sort of have that shared decision-making discussion about what's the appropriate treatment. And then the extension clinics that we currently have are our sedation-free clinic, where we're trying to see these patients and referrals sooner so we can get them into either a string or a transnasal clinic to get their assessment done quicker. And then we're rebooting our EOE support group, which started last month. Yeah, so the growth of this program has been amazing since I've been here over a decade. And then thank you to everyone, and then my family, and then sure Colby wants to take this one. And then so this is a capture of our sedation-free program. You can take a picture of that and sort of look at what our indications are and age and things like that. That's your grant. Make sure you get your credit.
Couple quick questions from the chat. And then Williams, excellent talk, Shauna and Colby. As the field of biologics is exploding in EOE as it is in IBD, what's your view of primary GI versus subspecialty multidisciplinary clinics' role in management of biologics and training of primary GIs, including community-based GIs?
Thanks, Dr. Williams. That's a great question. This is an evolving landscape, as you mentioned. And so it is really important. A lot of these biologic medications do not only impact the esophagus. So having these multidisciplinary clinics alongside an allergist, which is often the other indicated diseases where they're implicated or used, is important. It has important outcomes for eczema and asthma that need to be monitored in response to those therapies as well. There are a lot of community GI practices across the country, and they may not have access to those cares. And so having the time set aside to talk with the community allergist or feeding therapist or primary care physician is vastly important, especially when we can't work directly with those patients in the clinic.
Another question from a PCP in the community. Great presentation. Given that EOE is a lifelong chronic disease, is there a bridge to adult GI, or until what age do PCH GI see them?
I think this is like a very complex question. But yes, there are a few adult providers that we've identified in the community that will happily take our transition patients. We're trying to work on a transition clinic. Dr. Wright is actually adult and peds allergist at Mayo, and he has an adult EOE clinic. So depending on insurance, that's a great way to have that transition to like Mayo Clinic, for instance. I know the people at Banner. But as far as doing these less invasive testing, no one else is doing these. And so I'm really struggling with sending my 22-year-olds to then now have to go get a sedated scope. So I've started working with these adult providers, and if we do transition, they will send them back for their assessment, and then they will manage results. So I'm just a technician eventually. So I phase out as their primary caretaker and then just be sort of a technician for either sedated endoscopy or strain. So, but that's how we've been doing it. I haven't we need to be better, I think, in all subspecialties of transitioning our patients, but it's challenging.
Okay, we'll get one question to the audience and then we'll get everybody back to the same patients. And then everybody get your phones out. It's easiest evaluation ever. You just one question for a number and one comment. That you optional comments.
There's a question in the audience.
So it seems like with certain conditions like autism or prior surgeries, the risk is much higher and the symptoms are quite vague. So I'm wondering, are there like screening tools or screening questions so that I'm not sending everyone with autism and picking EP?
Yeah, no, that's a great question. So the impact screening tool can be used to look for those more food accommodation questions or ways that we're compensating. And then it really does depend on the age. We don't have like a validated screening tool or survey that the families can fill out to this point, but I would suggest kind of looking at this scoring system and asking these more broad-based questions to learn more about the child's feeding, whether they have autism or prior surgery, and just maybe paying a little closer attention in those cases where the risk is higher. But yeah, unfortunately right now, there's not a validated screening survey or tool that we can use for a lot of other diseases in the primary care clinic.
The other is like if they're atopic. So if you have an ASD patient that's atopic, send them. They have feeding issues.
And it may not be reasonable to ask all of these questions in a primary care or well child check, and that's where we're happy to lean on us for support and even see the patient. If you have a concern, then we can kind of further assess in our clinic and decide, is this concern something we can monitor and see if it progresses versus something that really needs a diagnostic endoscopy.
Any more questions? Feel free to come forward. We'll let you go.